Thank you for this opportunity. We have no disclosures. Numerous studies have highlighted the low instrument utilization within surgical trays, which results in excess processing costs and surgical case setup time. Additional issues related to excess surgical instruments include a reduction in instrument longevity, increased risk for tray assembly errors, and unnecessary strain placed on operating suite staff from tray weight. We aim to evaluate instrument usage within our gynecology surgical trays to reduce unnecessary instruments. Further, we estimated cost savings from the development of a minor gynecology tray for selected benign outpatient cases that would replace the standardly used vaginal hysterectomy tray. This was a single-site observational study within our gynecology department that occurred in 2 phases. First, surgeons and operating room staff eliminated extraneous instruments based on clinical experience. Second, a streamlined minor GYN tray was created for benign outpatient cases. Cost of sterile processing and packaging was estimated at 51 cents per instrument based on published data. During the study period, the Surgical Quality Committee also initiated a formal audit of surgical instrument usage. The standard vaginal hysterectomy tray contains 67 instruments. This was reduced to 48 instruments in the minor GYN tray. 844 cases were performed during our study period. The formal audit revealed instrument utilization to be 66% overall in GYN surgery, which is higher than what has been reported by other studies in gynecology. Processing costs were estimated to be about $34 per vaginal hysterectomy tray and $24 per minor GYN tray. Estimating that the minor gynecology tray could be used for 20% of those cases, we achieved a cost savings of more than $1,600. Cost savings are likely underestimated due to the surgeon and operating room staff-driven initiative to reduce the number of instruments used in each tray prior to the formal audit. Healthcare costs related to setup, processing, and packaging of unused surgical instruments can be reduced when surgeons and operating room staff work together to reduce inefficiencies. Healthcare costs are increasing, and hospital systems are tasked with finding opportunities to reduce costs while providing safe, high-quality patient care. Department audits can provide utilization data that should be used to eliminate redundancies. The development of a minor GYN tray can improve efficiency in benign outpatient cases. Even conservative estimates demonstrated a cost savings for our department. More importantly, advantages regarding time to set up and process instruments, as well as instrument longevity, cannot be underestimated. Thank you, and I welcome your questions.
Thank you. Are there any questions from the floor?
I have one. Not being a surgeon, what were you doing with all those other instruments that you could cut it? I mean, really, well, what was that like, just in case something happened, or?
So a lot of the studies have shown that instrument utilization is only 25%. So our 66% is much higher than what we've seen in the literature. But probably about 15 instruments that were removed were either towel clips or extra clamps that just were used less than 10% of the time. So the formal audit of our entire surgical core, which showed that we could save $325,000 by doing these audits, removed instruments used less than 10% of the time, and kept them separately packaged in case they were needed. Instruments that were not removed were things that were needed in an emergency, although they may be used less than 10% of the time, but could be needed in a very acute fashion.
So also on that note then, the fact that this was surgeon and operating staff led is laudable, isn't it? Because they're empowered to make the change.
Absolutely.
But you didn't report any harms. Were there occasions where an instrument was needed and wasn't immediately available, which would negate some of your cost savings? And were there any patient-related consequences of this change?
That's a great question. In our audit, we didn't find any that were specifically related to those instruments. And again, instruments that surgeons and staff decided were absolutely needed in the case of an emergency. For instance, an Anderson clamp for the IP ligament. Those were left in the tray, although used not frequently. So, thank you.
Thank you. If there are no more questions, thank you very much.
Thank you.
The next one will be educational electronic referral interventions on improving incontinence screening among primary care providers. By Y? How do you say that?
Can you see
Jen.
Ms. Dani?
It's harder than Italian names.
Yeah.
I'm Dr. Yazdani, and I will be presenting educational electronic referral interventions and improving incontinence screening among primary care physicians. No disclosures. So urinary incontinence is a widespread condition affecting millions of people worldwide. It impacts the quality of life of women. Unfortunately, women don't seek care secondary to embarrassment or difficulty bringing it up with their physicians. And primary care physicians and gynecologists in general do not screen regularly patients for urinary incontinence as part of their general practice. And this was studied at our own institution amongst gynecology residents who screened their patients 4% of the time based on a chart review. The aim of our study was to evaluate educational interventions on resident practice patterns in a primary care setting. And the goal here was really to improve the screening rates of women over the age of 40 who were coming in for a new patient visit, to improve primary care treatment of urinary incontinence in the clinic setting, and to see if this had any impact on the referral rates to our subspecialty clinics in urogynecology in this county hospital setting. Keep going the wrong way, sorry. The methods were a prospective cohort study design. We designed the study based on a quality improvement format with the Plan, Do, Study, Act technique. This involved a 3-part lecture series to internal medicine resident by a urogynecology fellow. We gave residents during the lecture, the lectures were really targeted to be very practical, not as much knowledge-based, but more specifically how to diagnose the condition, how to do basic treatment in a primary care clinic, and then how to refer patients if necessary. So we gave residents a DOT phrase that they can use as part of their history and physical based on the WHO guidelines, as well as these really quick blurbs on if you diagnose stress incontinence, how do you do basic conservative therapy for the patient. And then in our system, we use an e-consult format, and we actually showed residents how to use the format to refer patients to our subspecialty clinics. So really a practical guide. We collected demographic information from patient charts. We looked at the number of patients screened, treated, and referred to specialists for urinary incontinence, and we performed statistical tests. So this is a table of the results for the demographic variables, pre-intervention and post-interventions. No real difference between the two groups. Approximately 200 charts were reviewed in the pre-intervention and 92 in the post-intervention over about a 12-month period. Many of our patients are of Latina or Hispanic background, and the primary language spoke at our institution is Spanish, with some English speakers as well. There was slight differences in the number of average comorbidities and percentage of Spanish speakers pre- and post-intervention. So for screening, diagnosis, and treatment for urinary incontinence pre- and post-intervention, we found no statistical difference between the two groups, pre- and post-intervention, for screening of urinary incontinence, with a very low rate of 12% pre-intervention and 15% post. Positive screening, once they were screened, did they actually screen for incontinence, and then was a treatment offered for patients? And again, no difference pre- and post-intervention, and the numbers were so low that there was no statistical significance between the two. So we found that this very common way of actually increasing urogynecology referral pools, which is a lecture-based intervention, was not very effective in this setting. We're hoping, as part of the quality improvement guidelines, to do a secondary intervention using the patient as the, like creating posters so patients can actually discuss with their physicians, their condition, or doing it as part of a electronic alert in the patient chart, which would require further intervention. Thank you very much, and I welcome any questions.
Dr. Gibson.
Thank you, Professor Wag. I'm Bill Gibson from Edmonton. Given that every other study that's tried to use a single educational intervention has shown no effect whatsoever, were you surprised by these results?
Yes, because I think that what we were trying to do is a little bit different. It wasn't just, I guess, a lecture-based kind of knowledge, because there's the gaps are threefold, I think, in the primary care setting. One is it knowledge that is lacking? Is it actually a time issue, or do they not have the resources to do the referral? So we tried to do like a three-pronged approach in this setting. Unfortunately, all three didn't seem to work. Maybe physicians need financial incentives, I don't know.
American physicians do, yeah.
So on that line then, you said your next step is to plan a more effective intervention. Now, knowing what you do of the gaps, what is your magic bullets? Because it'll be multifactorial, won't it? What are you going to do?
Yeah. So I think, not to give away my full study design for the next project, but one of the things we're thinking is to attack it in different ways. So one is to get the patient as a partner, so putting up posters in the primary care setting that give patients kind of the liberty or the comfort in saying, hey, we will offer this treatment, just bring it up to us. So that's one thing. And then the other is to think of physician incentives that might help. And then the third is to get buy-in from the health system that we work in to see if they'll add it to the medical record as like a reminder to physicians. And again, that one is a little bit harder.
So I suspect there might be some audience members taking notes, so I should stop there. Thank you very much.
Okay.
So next study research priority.